Good afternoon. First of all, let me thank the organizing committee for the nice invitation. This is my 5th year on this conference. I'd like to thank Dr. Abdullah, Dr. Rosano, and Dr. Nadia. So we'll talk about this myocarditis. I don't know why Dr. Abdullah pick up those topics for me. I have a big disclosure before we start. I'm really a plumber. I'm an interventional cardiologist. So according to my sister, that's only plumber only knows about stents and balloon. So how can I talk about myocarditis and fulminant myocarditis? So let's try to see if a plumber can cover this. So I'll cover that through through those 3 publications, 2 of them from the American College of Cardiology recent, and 1 from the European Society of Cardiology. And really, if you have a time, try to look at those publications that give you a lot of information. So fulminant myocarditis is a sudden and severe inflammation in the myocardium, resulting in myocyte necrosis, edema, and cardiogenic shock. So this is associated with some systemic infection or inflammatory symptoms like fever and dyspnea. The other presenting symptoms could be chest pain or arrhythmia. So, and fulminant presentation is really a marker of robust inflammatory reaction that the body is trying to control and clear and cause effective viral clearance. So this is, although it's fulminant, but it's predictive of myocardial recovery among those with infectious myocarditis. So this is the main 3 presentation: chest pain or arrhythmia or heart failure. As I said, with chest pain, there could be associating fever and dyspnea, but we'll concentrate on heart failure and cardiogenic shock. These are all the common findings and reasons for acute or inflammatory cardiomyopathy, but we'll concentrate on the viral. The most 2 common viral things are Coxsackie and parvovirus, but I'm sure everybody noticed the incidence of COVID myocarditis and also vaccine-associated myocarditis. So there are some features in the history to give you something about the cause of the myocarditis. If there is a recent viral infection and there is recent viral symptoms or vaccination, that may suggest it's viral. Exposure to cardiotoxic agent, and now with the cancer therapy, immune checkpoints inhibitor, and we'll have a talk later on that, and other cardiotoxic drug. But there is family history for myocarditis or cardiomyopathy, and the 2 common mutation that whether the desmoplakin, we know desmoplakin is usually associated with cardiac arrhythmia and arrhythmogenic right ventricular dysplasia. But however, if there is any history of family history of this mutation, that may be cause of acute fulminant myocarditis. And the most common mutation is the titin mutation. And if there is a history of titin mutation, that may be predictor of the myocarditis. And if there is in the medical history of autoimmune disease, whether it's lupus or rheumatoid scleroderma, or the presence of sarcoidosis, that gives us the clue for the cause. The ECG findings is could be mimicking acute coronary syndrome, could be ST elevation or T-wave changes. The troponin is almost elevated because of myocardial injury. So we have to get low threshold to rule out coronary artery disease. And taking any patient with myocarditis to the cath lab to do coronary angiogram, that's a good decision. The BMP is elevated because of the congestion, and it has prognostic factors. So any elevation of the BMP could predict heart failure, and we need to follow that. So I'll leave the registry. So let's go to the echo finding. Could be just normal LV dimension, although the patient is presenting with heart failure, but the LV dimension is normal, not dilated left ventricle, because it's an acute injury. Increased thickness in the myocardium, that's not due to hypertrophy, it's just due to edema. Pericardial effusion could be present. Increase wall thickness, that's dynamic. If the edema decrease in the myocardium, we'll get a better result. And the greater ventricular dilation may suggest a chronic inflammation. This is an echo finding. You see that there is no dilation of the left ventricle, but poor LV function with MR. The fulminant myocarditis could present with arrhythmia, whether bradyarrhythmia and high-degree AV block, or ventricular arrhythmia. So the cardiac resonance, myocardial resonance may help us, and especially the T2 scan, that's represent myocardial ischemia. So if it's increased T2 in the cardiac MRR, that's represent edema. However, the LGE, late gadolinium enhancement, represents scar, and we need to follow that. Now, the myocardial biopsy is an important and prognostic factor, and also help in planning the situation for the treatment. And you go through the RV, directing that to the septum with the help with the echo, and get that. Just remember, the effectiveness of the biopsy is only, the yield is 30 to 40%, unless the patient has what we call giant cell myocarditis, where its protective value is more than 80%. So the recommendation is only to get it when the patient is unstable or in stage D myocarditis, that's been with heart failure or requiring myocardial support. But the other, if the patient is unstable, is a recommendation from the European Society of Cardiology. However, still with that, only 30 to 40% of our patients with fulminant myocarditis are getting the biopsy. The risk could be ventricular arrhythmia or cardiac tamponade, but however, the benefit may give us the diagnosis and may give us also the prognosis and the type of the inflammation. So if you get myocardial biopsy early, look at that. Just taking the biopsy early, that improves survival, because we are putting the right plan for the treatment of the patient. So the myocarditis with the biopsy, we have three types. Either we have the lymphocytic, you see this is the lymphocytic or purple cells, or we have the eosinophilic myocarditis, a lot of eosinophil, and that's, look at this pink and red with some myocardial necrosis. And giant cells have this giant cell with multinucleated cells. So those are the three types. The most common one is 80% of the cases lymphocytic myocarditis, and eosinophilic myocarditis 10%, and giant cell is only 10%. However, we have to remember the sarcoidosis, where there is this what we call it, like tuberculosis without any necrosis in the center, those granuloma, and this could happen in the septum and cause high-degree AV block. According to the type, we can put the treatment for that. And the treatment is mainly just supportive for lymphocytic myocarditis. There is debate whether we get benefit from steroid or antimetabolite. However, if there is eosinophilic myocarditis, the patient may get benefit from steroid and adding another treatment, immunosuppressant or antimetabolite. And the giant cell myocarditis had the poorest prognosis, so we need to get a lot of immunotherapy on top of steroids. Whether this is the steroids, whether steroids are benefit with simple lymphocytic myocarditis, we don't know. We are waiting for this myth study, the methylprednisolone therapy study trial to predict whether it's effective in lymphocytic myocarditis. The prognosis is, according to the type, as I said, just giant cell myocarditis, it has the poorest prognosis. And now what we do with the patient is just to give hemodynamic support. Just give him hemodynamic support until the myocardium recover. And that's the most important thing. And to give that, whether putting the patient on ECMO or Impella, that's within 3 days, we'll get improvement, hopefully. And now, what are the predictors whether the patient are benefiting with that myocardial support or not? I need just 1 minute. So those are the predictor. If we do right heart cath, and from the right heart cath, get the measurement of the right-sided pressure with the right atrium, the right ventricle, the pulmonary artery, and the pulmonary wedge, it's not just enough. Look at this case. I just showed you a case, elevated right atrial pressure, elevated right ventricular, elevated wedge. However, the cardiac output is very low, and the cardiac index is very low, and the systemic blood pressure is on the borderline and low pulse pressure, but need to do more calculation. Calculate the SVR, and the SVR, if it's elevated, that means really true cardiogenic shock. The body is trying to constrict in order to protect the other organ. Try to measure the ratio between the right atrial and the wedge pressure, and if it's elevated more than 0.6, that suggests congestion. And the PAPI, pulmonary artery pulsatility index, that's when we measure the pressure in systole and diastole in the pulmonary artery and divide them on the right atrial pressure. And that's, if the PAPI also is reduced, that means high risk patient. Can I get 30 seconds, please? And the last one is the measurement of the pulmonary vascular resistance. And this thing Dr. Hani Sabur mentioned about that. So that's the pulmonary vascular resistance should be below 2. And the last thing to consider is the CPO, the cardiac power output. That's when we measure the mean arterial pressure multiplied by the cardiac output divided by 451. And the normal should be always above 0.5. If it's very low, look at this case, 0.3, that's really poor prognosis. So depending on the cardiac power output, we can predict which patient is a high risk, and we need to do more. So those are predictor of this. I mentioned about the cardiac power output, the history of cardiac arrest before starting ECMO, high ECMO flow rate, that means the patient is not pumping well, the CNS event, or the need for the need for dialysis. All of that are poor risk prognosis. So the predictor, if the patient got full recovery within 3 days, that the heart improve, the function improve within 3 days, that's good prognosis sign. If we are exceeding the 7 days that the patient is still requiring myocardial support on ECMO, that's a poor prognosis, and we need to maybe refer the patient for transplantation and further. So can I get the last slide, please? Just last slide. Okay, so let's put it on the last slide, please. Okay. So this is the, it's not there. Can we put here? I need to show the, okay. So this is the unloading thing. Just remember, if we put the patient on ECMO, although we are resting the heart, but we are elevating the pressure inside the left ventricle, have to vent the ventricle either by putting an extra device like the impella or venting the ventricle. Otherwise, the patient may get acute pulmonary injury. And if we get pulmonary injury, look at the chest X-ray on the other side. When we get pulmonary injury, that means we are doing bad things to the patient, and the mortality will go high. So those are the important things that I wanted to cover in fulminant myocarditis, and I gave you some tricks about how to evaluate this from the hemodynamic and predict who's the patient at high risk from those hemodynamics. Thank you very much.